CBC by assessing hemoglobin and hematocrit levels. Now, these are the main components of the CBC. These are the various parameters that are there. The RBC count and hematocrit measure the red cell mass that carry the oxygen and carbon dioxide from lungs to tissues and back. The hemoglobin, which is the main component of the RBCs for gas transport. The RBC indices, red blood cell indices, very important because the calculated values depend on the size of the red blood cells and the hemoglobin content of the RBCs. And these indices are very important for evaluation of the various anemias. They, of course, can be altered by different factors like leukemia, heparin concentration, etc. The WBC count and the differential WBC count, very important, tell us about the increase or decrease in normal cells as well as the presence of abnormal cells. A peripheral blood smear examination, important information on all the blood cell components as well as for blood parasites. The mean platelet volume measures the average size of the platelets in blood, and that's the normal range as given over here. ESR, important parameters still, although a lot of pediatricians today ask for the CRP instead of the ESR. ESR still is of importance, especially in conditions like autoimmune disorders, rheumatoid arthritis, because somehow for reasons unknown, the CRP doesn't show up in those inflammatory conditions, and it is still the ESR that is used as a measure. Now, all these factors can be altered by pathology or by many physiologic conditions like stress, excitement, and exercise. Now, this is how a typical hemogram looks like. These are printouts that have come from machines. We have excellent quality machines for hemograms in our hospital that give us a lot of the data that we see. Like as seen over here, can be seen that the MCV and the MCH are on the lower side, indicating that there's a microcytic hypochromic effect on the red blood cells. All other parameters are normal. So this is an anemia in a patient. Another hemogram when you can see that the WBC is on the borderline and the platelets are very much lowered at the critical alert of lower. We have a robust transplant program here, bone marrow transplant. A lot of patients here are admitted for leukemias, for follow-up, bone marrow transplant, and again for follow-up. So you see a lot of CBCs with very low platelet and WBC counts, and they are treated accordingly. This is again some pictures of the peripheral smears that we get. Here you can see schistocytes, which indicate microangiopathic hemolytic anemia. You can pick up a lot of information from the peripheral blood smears. It is one of the dictums that we lay down that however good our Ulta counter machines are, whatever excellent reports they may generate, but seeing a peripheral blood smear examination through the microscope is compulsory for all pediatric patients, and that is what we follow over here. You can see sickle cells, target cells, a lot of red cell morphology and analysis of anemias can be done by looking at the peripheral blood smears. Leukemia, WBC, as you can see here, abnormal and large. Some of them are having these OR rods. You can pick up abnormalities there. You can pick up a lot of platelet abnormalities on the peripheral smear. Here you can see them in clumps. So even if you get a low platelet count on the counter, it's compulsory that you see the smears. This could be due to the anticoagulant EDTA. There are only 2 or 3 conditions where you get a low platelet count on the counter, which is wrong. One of them when they are in clumps, one when they are very large platelets because they're not counted as platelets, and ones where there can be agglutination due to EDTA. So seeing a peripheral blood smear is absolutely important. Now we come to the next common investigation after the CBC in our setup, and that is the PT-APTT. The PT takes part in the extrinsic coagulation pathway and the APTT in the intrinsic. Both of them then are also responsible for the common pathways that take place. Now, in the extrinsic pathway, you have factor 7 along with 10, 5, 1, and 2. And in the intrinsic, you have factors 12, 11, 9, and 8, along with again 10, 5, 1, and 2. Now, prothrombin time, Besides all these factors, is often used to monitor patients taking warfarin. The results are reported as INR, that is International Normalized Ratio, which helps standardize results between the different labs. The APTT, besides all these coagulation factors, is used to monitor patients taking heparin. And instead of a plain PTT, an activated like kaolin is added, and it is known as activated partial thromboplastin time, which is more sensitive than a simple plain PTT. Now coming first to the PT-INR. It's used to monitor how warfarin is working. I've already said that. It's used to plan for surgeries, to check that the blood has normal clotting properties, to diagnose blood clotting disorders, and to check for various liver conditions. It can signal liver disease. A PT test is one of the several liver function tests used to determine how advanced liver disease is. The normal ranges for PT-INR are PT is 11 to 13.5 seconds and INR in the range of 0.8 to 1.1. If a patient is on warfarin, then the INR will be raised 2 to 3. So whenever we do get results where the PT is raised above these ranges, it is our job, our technical staff is also trained to ask questions about the history of the patient and what drugs the patient is on so that we can correlate the results. If not on warfarin, it could be a sign of bleeding, blood clotting disorder, a liver problem, or deficient vitamin K. It's very important to collect samples for PT, APTT from non-heparinized lines, as this then affects the results. APTT, prolonged APTT, is due to these factors as stated here: deficiency in the clotting factors, presence of circulating anticoagulants, heparin therapy, liver disease, or other conditions that affect clotting factors. A short APTT can indicate a tendency for blood clots to form and a problem with the immune system with maybe certain antibodies against these factors. Normal range is about 21 to 35 seconds. Results slightly vary from lab to lab in their normal ranges depending on the equipment and methods used. Standard normal results always vary from lab to lab. This is just, I want to show you how our results are come out from the machine. Here you can see the PT time is given as 14.3 seconds. And this is how a PT is calculated. Take the prothrombin time of the patient sample in seconds. And you divide it by the normal prothrombin time, which is calibrated and calculated and put into the machine. And that is multiplied by the ISI. ISI is the International Sensitivity Index, which is there printed on the kit insert of the reagents which we use. So the normal PT in seconds as well as the ISI, both are fed into the machine. What we have to do is just to test the patient sample, and the results are calculated and you get the INR. Like over here, 14.3 seconds is the reading of the patient sample. 12.4 seconds is the standard normal fed into the machine. ISI 1.01 is standard ISI again fed into the machine, which is there on the reagent kit inserts. And with that calculation, you get a reading of 1.164, and that is the reading that we get. So this is how RPT is calculated. The International Sensitivity Index is a value assigned to a thromboplastin reagent that indicates its sensitivity compared to a reference thromboplastin. And that's how this helps to standardize prothrombin time and the prothrombin time results and the INR also. And this is there on every reagent that is used. Now that finishes the basic hematology tests that we do in a lab, and we come to the now blood chemistry panel. It is also known as the basic metabolic panel or comprehensive metabolic panel, and it provides information about the levels of various chemicals and substances in the blood. This includes liver function tests, renal function tests, electrolytes, and blood gases. These tests are crucial for identifying metabolic imbalances, diabetes, kidney disease, liver disorders in pediatric patients. They are particularly also effective and important in monitoring the effects of medications and assessing a child's overall metabolic health. The liver function tests. These are used to assess liver health, to monitor existing liver conditions, to investigate unexplained symptoms, and to screen for inherited liver diseases. The main NFTs that we do are enzymes, the transferases, the GGT, gamma glutamyl transferase, and the alkaline phosphatase. We test for proteins, albumin especially, bilirubin, a waste product from red cell breakdown, and PTINR. The tests that evaluate liver function can be divided into 5 categories. Those that indicate liver injury, that is the enzymes, the transferases. Those that indicate impaired bile flow or cholestasis, that is especially alkaline phosphatase and GGT. Tests that cause or indicate impaired liver synthetic functions like the serum albumin. And tests that show impaired hepatic excretory functions like bilirubin. And there are certain tests that are responsible for metabolic functions like ammonia. Now, liver disease can be either due to hepatocellular injury or biliary disease, that is cholestasis. When there is hepatocellular disease, one should note that there is a marked elevation of serum transferases compared with alkaline phosphatase, whereas when there is biliary disease alone, there is a rise in the cholestasis as compared to the transferases. But in both these conditions, that is hepatocellular disease and biliary disease, other LFTs like bilirubin, albumin, prothrombin time, INR may also be changed. In suspected cases of hepatocellular and biliary disease, the following causes must be considered: viral hepatitis, medication. Almost any medication can cause an elevation of liver enzyme, and this is especially important in our setup where we have a robust bone marrow transplant program where a lot of medications are used and which can alter the liver function parameters. So a history of medication is very useful. The other causes which are there, hepatic causes, where only the enzymes are raised. Other parameters are not much affected, and these other conditions are autoimmune hepatitis, where a liver biopsy is needed for confirmation, Wilson's disease, glycogen storage disorder, alpha-1 antitrypsin, and biliary disease. Some of these need a liver biopsy for confirmation. There can be a large number of non-hepatic causes of elevated liver enzymes like muscle disorders, cardiac and thyroid disease, celiac disease, rare cases of adrenal insufficiency. When there is persistent rise in the enzymes, the transferases, greater than twofold, more than twofold the upper limit of normal, and if many other tests are ambiguous, a liver biopsy is recommended. Otherwise, a liver biopsy is not usually recommended. Now, coming to renal functions, there are various renal functions, and any abnormality in any of these functions affects the various tests that are there under the renal function tests. Now, what are these renal function tests? The kidney lab panel can vary from lab to lab, but some of the typical tests are as shown over here. Electrolytes, which are very vital for nerve and muscle function, sodium, potassium, chloride, bicarb, minerals like phosphorus and calcium, which are vital for energy production, muscle and nerve function. And calcium is also very important for muscle, nerve, heart, and for formation of healthy bones. Protein, albumin, prevents fluid from leaking out of blood vessels and transporting hormones, vitamins, drugs, and ions like calcium throughout the body. Waste products, BU and urea, which form from the metabolism of protein. They are released into the liver, carried to the kidneys, and filtered out. Creatinine, most important waste product produced by the body's muscles. Almost all creatinine is eliminated by the kidneys. Important to remember that about 50% of kidney function must be lost before rise in creatinine can be detected. The serum creatinine is a late marker of acute kidney injury, and uric acid also is a waste product. Then other tests included in the renal function test are glucose, which is the energy source, and other parameters like BUN creatinine ratio, urocreatinine ratio. All these are important parameters. Urine analysis is important, measured for volume, hematuria, osmolality, minerals, urea, protein, glucose, and minerals. What can be seen is last line is the renal biopsy. Certain cases, it's not the norm to do a renal biopsy, but it's done more for when there's no response to treatment or as a follow-up event. Heuristics, one line on heuristics. These are strips impregnated with reagents for the substances to be measured within a urine sample. Whatever is the substance, whether a protein or nitrate, can be altered, especially increased if there is pathology within the urinary tract. Measured substances on these dipsticks are protein, hemoglobin, glucose, urobilinogen nitrite, leukocytes, specific gravity, and pH. Dipstick should be a tool which is used everywhere at the level of primary care and should be easily available. Next. Next, coming to the next common investigation is serum electrolytes. Electrolytes like sodium, potassium, chloride, calcium, magnesium, phosphate. They are essential for maintaining proper nerve muscle function. Children are particularly vulnerable to these imbalances due to their small size, fast metabolism, increased risk of dehydration from vomiting, diarrhea, and fever. Conditions like chronic kidney disease, heart disease, and certain medications cause these electrolyte imbalances in children. These are the various imbalances. As you all know, they can be hypo or hyper for sodium, potassium, as well as calcium, which can be dangerous, affecting a large number of functions and have to be corrected immediately. Most pediatric setups have regular panels showing the correction for these electrolytes, and electrolytes should be corrected slowly to avoid complications. And early detection, identification of these imbalances are important. And to understand that, one should know also the pathophysiology of the underlying electrolytes and the underlying disease. Coming to the next parameter, important one is blood gases, and especially I like to stress on ABG. It is a test that measures the level of oxygen, carbon dioxide, bicarbonate, along with the blood pH to assess it. It's a valuable tool to evaluate respiratory diseases and conditions that affect the lungs, to determine the effectiveness of oxygen therapy, to diagnose and monitor conditions that affect your lungs and kidneys, and to assess overall acid-base balance. The test is performed by drawing a blood sample from an artery in a heparinized syringe and sent to the lab on an ice pack. This provides a more accurate indication of oxygenation than a venous sample. The pH is usually 7.35 to 7.45. It measures the acidity of the blood. Partial pressure of oxygen shows how well the lungs move oxygen from the air into the blood. Partial pressure of carbon dioxide, how well the lungs remove carbon dioxide from the blood, the bicarbonate, and the oxygen saturation. Now, acidosis caused by the lungs, respiratory acidosis caused by the lungs not removing enough carbon dioxide, and alkalosis caused by the lungs removing too much carbon dioxide, especially like when there is hyperventilation. Metabolic acidosis caused by a buildup of acid in the body, and alkalosis caused by loss of acid or a gain of base in the body. Now, I'd like to show you one of our reports at least. Like this particular case, we can see the pH, it is acidic. The carbon dioxide is almost within the normal limit towards the higher range, but PCO2, but towards the within normal. Bicarbonates are low. Lactic acid is high. So, with the low pH and normal PCO2 and a low bicarbonate, it indicates that it is going into metabolic acidosis, and correction can be done. First check for compensation and then for correction. These are the various steps. All pediatricians are well aware of these 6 steps for analyzing ABG results and treating accordingly. So I do not need to go into that. And there may be charts available in all intensive care units regarding this and the corrections. Next we come, so I took the basic tests that we do in biochemistry in our laboratory, that is the RFTs, the LFTs, the electrolytes, and the blood gases. And I come on to clinical pathology. I'll take up an important small thing, an important aspect of the CSF. Why do we examine CSF? Diagnosing infections, evaluating other neurological conditions like subarachnoid hemorrhage and certain types of tumor, and also to monitor disease progression. for certain conditions like leukemias and their follow-up. What are the various parameters seen for CSF? Appearance, cell count, the number of white blood cells and red blood cells in the CSF is assessed. In neonates, the normal CSF WBC count can be higher than in older children, with some studies suggesting a range of 0 to 15 to 30 WBCs per cubic mm. Glucose levels, CSF glucose levels are compared to blood glucose levels, should be greater than 2/3 of the blood sugar level. The protein levels, CSF protein levels are measured and generally around 15 to 45 milligram percent. CSF samples can be cultured and other tests like PCR chain reaction are done whenever required. Now that is about the common and important clinical pathology investigation we do besides urine analysis, in which I have briefly touched upon when I was dealing with the dipsticks. Can't go into further details because that is a class by itself. Very briefly on the other tests which will be dealt with more in detail by my colleagues. Thyroid function tests like hypothyroidism, hyperthyroidism can impact a child's physical and cognitive development and hence very important. Abnormal levels of these hormones can indicate an overactive or underactive thyroid. Allergy testing important because it detects sensitivity to common allergens like pollen, dust, animal dander, certain foods. It's important to develop effective treatment plans so that we can avoid allergens that are causing skin, respiratory, or GI problems. A family history of allergy is also very important. Genetic testing is done. Newborn screening tests, for example, are routinely conducted to detect conditions such as phenylketonuria, cystic fibrosis, and sickle cell disease. Can be used for diagnostic purposes in cases where a child exhibits developmental delays, intellectual disabilities, or congenital anomalies. I come back to my first slide, which I showed to show the common tests that are done in our lab. Besides all these tests, we do many other additional pediatric lab tests, which are not done often, done once in a way, not very infrequent too also, like coagulation profile, iron studies, lipid profile, vitamin assessment of D, B12, hormone levels, blood lead level, and various other tests also. I would like to state at this point that our laboratory is NABH accredited since the last 5 years. We have gone through 4 accreditations so far from the time after it has been set up. All quality work as per demands of the audit are met with the IQCs, the ECAS, the audits, internal, external, all are thoroughly done and all procedures are followed. All quality aspects like critical alerts, alerts for rejection, training, competency, everything is met with. Thank you. I pass it on to my colleague who will now take on specialized tests, Dr. Sheefali Jadhav.
Good afternoon, everyone. I'm Dr. Sheefali Jadhav, Junior Consultant Pathologist in the Department of Laboratory Medicine at SRCC Children's Hospital. Okay. So why generally specialty is required in pediatric? As the needs of the children in the 21st century differ from the needs of those in the 20th century, more attention is required to ensure optimal access, coordination, and the impact of health and well-being of infants, children, and adolescents. Children's rapid development renders them particularly vulnerable as delays in addressing help needs or defer care altogether may result in harmful effects both during childhood and which may also impact during adulthood if it is during the critical periods of development. So these are the various subspecialties in pediatric at SRCC Children's Hospital. We also have a transplant unit here along with pathology, lab medicine, blood bank. So let us start. I'm going to distribute this specialized investigation as per the specialty, that it helps you to like elaborate the various tests, why they are ordered in a particular department. Let us start with pediatric hematology. So this is the basic investigation which ma'am had already elaborated in CBC, PT, APTT, fibrinogen, a peripheral smear, which is utmost important. It can give you the diagnosis right away, whether it is malaria, whether it is a leukemia, whether it is any hemolytic anemias at times, a retic, which is also important, a bone marrow aspiration, trephine, your basic iron studies, B12, HPLC, immature platelet fraction studies, a thrombophilia profile, and other more specialized tests like a flow cytometry, karyotyping, cytogenetics, and clinical exome. Basic reticulocyte count, which is very important when you have an anemia, to recognize whether it's a hemolytic anemia, whether it is an aplastic anemia. It is also used to assess response to specific therapy in iron deficiency and megaloblastic anemia. Also, it is important to follow the course of a bone marrow transplant to see whether it has engraft or not. Also, reticular site count is done by manual method, and now in recent time, it is also done on flow cytometry. Bone marrow aspiration and trephine. Bone marrow aspiration and bone marrow trephine are important procedures for diagnosis of various hematological and non-hematological conditions in children. In bone marrow aspiration, analysis including microscopical, morphological, and a differential count is given for myeloid series and megakaryocytes. It tells you the adequacy of megakaryocytes, and erythroid, it gives you an ME ratio. A trephine, basically, the cellularity is better assessed on a trephine biopsy, and it also helps to rule out if the marrow is involved by any solid tumors, any lymphomas, or any other storage disorder. I'm sorry. So the common indication for a bone marrow aspiration, basically, in your leukemias, okay, in your aplastic anemias, to diagnose various hematological conditions where there is an hypoplastic inherited bone marrow failure syndrome. In pyroxia of unknown origin, it is done for microbiological cultures. In for investigations of hypersplenism, lymphadenopathy, mediastinal or abdominal masses, for follow-up of chemotherapy, generally for MRDs, and after a hematopoietic stem cell transplant. Common clinical indication for a trephine, as I had already mentioned, for an aplastic, it is important to always do a trephine biopsy. A cellularity should always be assessed on a trephine biopsy to investigate for certain lymphomas infiltrating the trephine, and certain small blue round cell tumors like a neuro, RMS, and Ewing's. It also helps in staging of the tumor in such cases. HPLC, which is a high performance liquid chromatography. It basically helps in diagnosing various hemoglobinopathies, the common ones like thalassemia, sickle cell, and an abnormal hemoglobin. It should be it should be done after the age of 6 months, because fetal hemoglobin is much more before that age. And if it's not possible, to please do HPLC on the parents. Immature platelet fraction. Immature platelet fraction is relatively like done on relatively done more nowadays. It is an indicator of a platelet production, and it is typically elevated in disorders of platelet destruction such as ITP, TTP, DIC. It is also an indicator of bone marrow recovery in post-chemotherapy and stem cell patient. A decreased IPF is indicative of decreased platelet production in the bone marrow. The normal range is 0.7 to 4.3. It is subjected to change as per the equipment and also as per the lab. Thrombophilia coagulation profile, it is basically it's a condition where the blood has an increased tendency to clot, which will lead to increased risk of blood clots in veins and arteries. Antithrombin 3, protein C, and protein S activity are natural anticoagulants which are assessed in the profile. Factor V Leiden and prothrombin gene mutations are common genetic mutation associated with increased risk of blood clots. Flow cytometry is nowadays very essential and done in most cases of leukemia. It is done to to know the lineage, whether it is B cell, T cell, whether it is myeloid, lymphoid, and whether it is myelomonocytic, monocytic, erythroid, megakaryocyte, because all this has treatment implication, and the treatment protocol varies as per the lineage. So the basic principle of the flow cytometry is measurement of the light which is scattered, and the fluorescence is observed when these particles are passed in a stream through a laser beam, and this is plotted on a graph which is analyzed and a report is generated. So as I told, the common indications will be in cases of leukemia, also in few cases of lymphoma. And generally, bone marrow transplantation is very essential to know the CD34 count with CD3. And in certain conditions like LSSA, lymphocyte subset analysis, and extended LSA, it is done by flow cytometry. And genetic disorders like PNH, which can lead to aplastic or an hemolytic PNH, is also analyzed on flow cytometry. A bit of pediatric solid tumors. Generally, a biopsy is done in pediatric solid tumors for a diagnosis. In few tumors, like a Wilms tumor and a neuroblastoma, necessarily doesn't require an IHC or a FISH panel, but it is very important in cases like if there is an alveolar, in case of lymphoma, in case of CNS tumor, because these basically lead to a conclusive diagnosis, and nowadays because of molecular, it helps in having a targeted chemotherapy approach. A pediatric endocrinology, as we say, there is one which is done for diabetes, like fasting PPBS, and HbA1c, fasting insulin, C-peptide, hormone level assessment, and genetic testing. HbA1c is a blood test that measures the amount of blood glucose attached to the hemoglobin. Basically, it gives you the this of 3 months of how your blood level are controlled. It is generally useful in diagnosis of type 2 diabetes. So where it is won't be of use, especially in cases of various hemoglobinopathies. The blood glucose won't be reliable. The test which to be used will be your GTTs, your insulin fasting, which determines the root cause of your low blood glucose levels if you suffer from hypoglycemia. It also identifies insulin resistance. It understands the efficiency of your current treatment plan if you have type 2 diagnosis. It monitors the working of your pancreas to understand if critical surgeries like islet cell transplantation are working effectively. I'm sorry. And then C-peptide. C-peptide, which is also ordered in the test panel if you have a suspicion of diabetes mellitus. It is a protein that is produced in the pancreas along with insulin. C-peptide levels can help you differentiate between type 1 and type 2 diabetes. It helps monitor insulin production. As ma'am had already elaborated on thyroid function test, these are very essential for the growth and development in the children. It helps in the growth along with metabolism and working of other functions. In your thyroid function test, you have normal thyroid function test and pre-thyroid function test. where the thyroid function test, which normal one, which has total T4, total T3 and TSH, and your free will have your free T3, T4 and TSH. Along with that, as you see, each condition, hypothyroidism will have a low TSH with high T4. Primary hypothyroidism will have a high TSH with low TT4. Along with that, we also have a panel of thyroid antibody tests. Basically, in an autoimmune thyroid disease, the blood-owned immune system attacks the thyroid, measuring levels of hence anti-thyroperoxidase or anti-thyroglobulin helps to determine a thyroid cause. A presence of antibody against the TSH receptor helps diagnose a condition of Graves' disease. Thyroglobulin is a protein produced by normal and abnormal thyroid test. This test is used in patients who have undergone surgery and radioactive iodine treatment for papillary or follicular thyroid cancer. Um, the test which is normally asked in the lab is 25 hydroxy vitamin D. It is a fat soluble steroid, which is a steroid prohormone. Vitamin D deficiency is associated with rickets in children. This is the range of expected value. The main this is deficient one, which it should not be less than 20, and more than 150 will lead to a potential toxicity. Growth hormone stimulation test. Growth hormone stimulation test is a medical procedure used to assess the pituitary gland's ability to produce and release growth hormone. It helps to diagnose growth hormone deficiencies where the body doesn't produce enough growth hormone. The medicines which are used for this growth hormone stimulation test commonly use is clonidine. Other hormones. Other hormones are like cortisol. Cortisol is also generally ordered in the lab. It basically helps the body to use sugar and fats for energy, and it helps the body to manage stress. Cortisol levels can be affected by many conditions, like physical or emotional stress, strenuous activity, infection, or injury. So this is most important for cortisol. The levels rise during the early morning hours and are highest among 7 a.m. and they drop very low in the evening and during the early phase of sleep. But if you sleep during the day and your pattern is reversed, so this might also be reported likewise. That's why the timing of the cortisol is very important, and the cortisol test is available as fasting, random, 8 a.m., 8 p.m. These are the hormonal tests which are also done in the pediatric population. Testosterone, which basically helps to diagnose cause of early or delayed puberty, assess potential damage or disease of related gland. It helps monitor hormone therapy, FSH and LH. In children, it is used to assess puberty, diagnose conditions like precocious puberty or delayed puberty, evaluate potential problems with the reproductive or the pituitary gland. In pediatric neurology, we have the basic CSF cell count, biochemistry, microbiology, autoimmune, or neurotransmitter panel. In blood investigation, we would have the routine blood investigation. We have creatinine kinase, homocysteine, B12, ammonia, vitamin D, and thyroid profile test. Along with that, a battery of genetic tests when and well required as per the condition. A bit about creatinine kinase. It is an enzyme that helps in producing energy from the muscle. It is found in striated muscle such as skeletal and heart. To a lesser degree, it is also found in involved in brain, GI, and urinary bladder. Increased amounts are released into the blood where there is muscle damage, such as an heart attack, strenuous exercise, also at times skeletal muscle injury. This test may use to detect these conditions like myositis, myopathies, and rhabdomyolysis. It has three subunits as seen on the screen. Homocysteine. Homocysteine is also one of the commonly tests which is asked in our pediatric neurology setup. It is an amino acid that is an intermediate into the production of two other amino acids, methionine and cysteine. Too much homocysteine in the blood has been associated increased risk of cardiovascular disorders, including venous thrombosis, atherosclerosis, high BP, coronary artery disease, and stroke. Autoimmune encephalitis panel. It is a group of basically autoimmune encephalitis. It is a group of syndrome that occur in association with autoantibodies, which are presumed to be responsible for encephalitis and further development of epilepsy. It generally involves B cell mediated autoimmunity, and this will be a slight indication that, along with definitely your signs and symptoms and your radiological investigations like MRI, this might also help in pinpointing that it can be an autoimmune encephalitis. Like there will be a slight pleocytosis, which is seen in 45% of the cases. Then the sugar will be normal at most cases, but there will be a elevation in protein, CSF protein, and you would find in oligoclonal bands, which is positive in many cases, especially with NMDA receptor antibodies. So these are the various antibody panels which are seen. Commonly one are the NMDA, VGKC, GABA, and GAD65. So these are the various diagnostic approaches used in the autoimmune encephalitis. There are advantage and also there are some falsies. Like if it is syndrome based criteria, the advantage of early immunotherapy can be given. At times, the disadvantage, it can be an incorrect, not helpful for differential diagnosis, can lead to overt immunotherapy. We now head over to pediatric nephrology. So as you know, like how it was the analogy of CSF for neuro, for nephro, it is analogous to urine. So we have our urine routine microscopy, 24-hour urine analysis, a culture sensitivity when as and when required, and urine osmolality. There is also a chunk of kidney biopsies, and their basic investigations, although like renal package 1 and 2, it will, as ma'am said, differ as per your institute. It has your basic BUN, creat, electrolyte, calcium, magnesium, phosphorus, and your whole lot. So a 24-hour urine analysis, why it is done? Basically, it is usually used for evaluating urinary stone disorders, proteinuria, pheochromocytomas, where it detects fraction metanephrines and catecholamines, and renal function is 24 hours urea and creatinine clearance. It can be done on an outpatient basis. Results are analyzed along with detailed medical and dietary history. Serum chemistry and stone composition also help in diagnosis and guide therapy. The urine study used in pediatric is also to test some inherited conditions such as primary hyperoxaluria and cystinuria. In pheochromocytomas and paragangliomas, there are elevated urine and plasma metanephrines, which might also nudge us towards that diagnosis. The collection procedure is similar. However, there are some various patient instructions which are always given before a 24 hours urine collection. Like in case of catecholamines, VMA, and metanephrines, first you have to contact your physician for approval, but obvious that these are the for 3 days before and during you should avoid certain medication, avoid certain food, and for 5 HIA, yeah, again you have to avoid certain medications and certain food substances. In renal biopsy. So this is how a division of kidney biopsy is done for light microscopy, for immunofluorescence, and for electron microscope. It is a very important diagnostic tool in the hands of a pediatric nephrologist. It can help in better delineation with the adjuvant neurostins, immunofluorescence, and electron microscopy. While they say it is more useful in the diagnosis of a glomerular disease, it also helps to provide information on certain tubular conditions as well. These are the few indication like a nephrotic syndrome, steroid congenital nephrotic, rapidly progressing glomerular nephritis, and these are the various points which can seen in light immunofluorescence and electron microscopy. In light microscopy, there is glomerular proliferation or sclerotic changes are seen. Basement membrane thickening is seen. In immunofluorescence, it helps in identifying whether you have immune deposits present or absent. Electron microscopy helps into the structural defects of podocytes, like which is very helpful in cases of nephrotic syndrome, which might show nothing on light microscopy, but it would show effacement in minimal change, and it also helps in identifying the exact location of immune deposits, whether it is subepithelial, subendothelial. This along with that, we also have urine and serum osmolarity and urine electrolyte. These are done in these following conditions: C3 and C4. So C3 and C4 are also acute phase proteins which are central in the innate and complement enzyme cascade system. The complement activation results in opsonization and lysis of pathogen. Low C3 and C4 are seen in immune complex diseases like SLE, cryoglobulinemia, sepsis, and it indicate classical pathway activation. Only low C4 can also be seen in conditions like autoimmune hemolytic anemias and C1 inhibitor deficiency. In complements, low C3 with normal C4 are indicates an alternative pathway activation and may be seen in conditions like sepsis, post-infection glomerular nephritis, and disorders resulting from abnormal regulation of alternative pathway. Uh, this assay is performed by turbidometry. Pediatric rheumatology. Here you would have a major chunk of tests which is done by immunofluorescence, your immunoblot based test, and your serum based test or plasma based tests like anticardiolipin, beta 2 microglobulin, immunoglobulins, and lupus anticoagulant, and also again genetic testing. ANA by immunofluorescence is to identify anti-nuclear antibodies. And may I just tell you that ANA should always be preferably done by immunofluorescence test. It is standardized and it is a standardized test to be done by always by an immunofluorescence method. The hep2 nucleus and primate liver nucleus is seen with the positivity, and a series of dilution is done on the chip, and it helps in diagnosing various autoimmune disorders like SLE, rheumatoid arthritis, scleroderma, and Joron syndrome. Your various nuclear patterns are there. You can see your homogeneous speckle, dense fine speckle, centromere pattern, nucleolar pattern, and this is the corresponding antibodies which is done on a by a method of immunoblot method. ANCA. This test basically looks for anti-neutrophil cytoplasmic antibodies. There are two kinds of ANCA, P ANCA and C ANCA. C ANCA corresponds to PR3 and P ANCA corresponds to MPO. An ANCA test can show whether you have one or both types of antibodies. You can see here, like C ANCA, it will be only cytoplasmic, small granularity would be there. And P Anka, this is done, this will give you like a popcorn wala morphology and appearance. ANA and Anka, basically these are done on your like your fluorescent microscope. One test which I didn't mention is dsDNA, which can be done on your immunofluorescence and also can be done on immunoblot assay. So these are the antibodies which are often asked in our pediatric rheumatology. The anticardiolipin antibody, which is IgG and IgM. Yeah, cardiolipin is an inner mitochondrial membrane component which compromise 20% of the total lipid composition. These are more sensitive but less specific compared to lupus anticoagulant for predicting thrombosis. Moderate to high levels of antibodies that persist for 12 weeks may indicate a continued presence of these antibodies. Beta 2 glycoprotein antibodies IgG and IgM. These are also suspected with Apla syndrome and also this but the thing is it should be done in conjunction with your cardiolipin antibodies. Your lupus anticoagulant, it is a protein that increases the risk of developing blood clots in both your veins and artery. This clots may block blood flow to any part of the body, leading to strokes, heart attack, pulmonary embolism, and deep vein thrombosis. Although anticoagulant is an acquired, not inherited condition, it is most frequently seen in autoimmune diseases such as systemic lupus erythematosus. It is thought to be present in 1 to 2% of the general population and may develop in people with no known risk. Pediatric pulmonology. So the tests which are generally ordered are the sweat chloride, IgE, cow milk, specific IgE, your bronchoalveolar lavage, which is done for a battery of tests, including culture sensitivity, gene expert, MGIT, biofire, and cytology. Along with that, genetic testing. Uh, a little bit on sweat chloride. Cystic fibrosis is a rare genetic disorder characterized by multi-system involvement, including progressive, potentially fatal pulmonary disease, which has been described as being the most prevalent inherited fatal disorder. The the regulator is at the apical portion of these epithelial cells in the airways, in the GI tract, pancreas, and the detection of the elevated levels of sweat chloride in a suspected patient is done by a quantitative pilocarpine iontophoresis test, which is considered a gold standard for diagnosis of cystic fibrosis, which is also done in our lab. Sweat chloride levels less than 30 is cystic fibrosis unlikely. 30 to 59 it is possible, but a further testing is required. 60 or more, there is it is likelihood of it being CF. For patients with intermediate sweat chloride, genetic testing may help confirm or exclude the diagnosis. A small this on pediatric immunology, which has tests like extended LSSA, immunoglobulin, NBT, and DHR. Extended LSSA, basically it goes much beyond your basic T cell, B cell, and NK and T cell subset. It is done for diagnosing and monitoring of immune disorder, especially in various immunodeficiency, pediatric as well as adult immunodeficiency disorder. It helps in monitoring therapy. It is also helps in predicting disease severity and prognosis. It assess immunocompetence. LSSA, a part of extended LSSA, is often done to see immune reconstitution in our post bone marrow transplant patient. Immunoglobulins. Basically, these are glycoprotein produced by the plasma cell. These cells are instructed by various specific immunogens to produce the various types of immunoglobulin. The immunogen or antigen react with B cell receptor on the cell surface of the lymphocyte. It outlines disorders with various immunoglobulin deficiencies are seen. This is the basic module of an antibody, and these are the various forms of antibodies. IgA, which is commonly secreted in the mucous saliva. IgE, which binds to mast cells and basophil, which gives us a this of allergies and anti-parasitic. And as you could see, it is was done in your pediatric pulmonology. IgG binds to phagocytes, mainly blood antibody for secondary responses. This is the one which crosses the placenta. IgM, which fixes complement main antibody of primary responses. Your nitroblue tetrazium test, just a basic information, it is commonly done for CGD. It helps to screen for chronic granulomatous disorders. It is a manual test. When the NBT is added to the white blood cells, and when it doesn't change the color, it means there is a deficiency of reactive oxygen species. And in DHR is dihydrorhodamine test. It is a blood test which also useful in diagnose CGDs. It is also known as neutrophil oxidative burst assay. It measures the ability of neutrophils to produce reactive oxygen species. It is done on flow cytometry. Newborn screening. So newborn screening is done in most of all the neonate care wherever it is available in the country abroad. It aims to detect serious but often rare health conditions in newborns before they cause significant health problem. These conditions can be genetic, metabolic, or development, and early detection allows for timely intervention and treatment. It should be typically done within 24 to 82 hours. The tests are typically performed when the baby leaves the hospital. If the baby, it should be also done before giving any transfusion to the baby. Okay, this is generally done by a heel prick test. A blood sample is taken from the baby's heel and sent to a lab for testing. These are the various condition, and as per the panel, whether it is two condition, four condition, seven condition, it now it is extended to 40 conditions also as per the doctor's orders and as per the clinical judgment for the patient. These conditions and choose the common ones are five condition. In all these tests, you have seen that a genetic testing plays a very important role nowadays in pediatric and especially in pediatric because genetic disorders. So a little bit, what are genetic disorders? These are due to alteration and abnormalities in the genome of an organism. A genetic disorder may be caused by a mutation in a single or multiple gene. Genes are basic unit of heredity. They hold the genetic information in the form of DNA, which can be translated into useful protein to carry out life processes. Some genetic disorders are innate, that it is present by birth, while others are acquired due to mutation in a particular gene. The genetic disorders that are acquired during the lifetime are not inherited from parents. They occur due to mutations that occur randomly or due to exposure to certain chemical. The genetic disorders are generally categorized in Mendelian disorders, which is a disorder in a single gene that follows the Mendelian inheritance pattern, and chromosome, where damage or alteration in the chromosomal structure or number, and where the chromosome is either missing, duplicated, or part is translocated. So, these are the various testing modalities for a genetic disorder. The commonly one which are done are the karyotyping, which gives you a structural change in a chromosome. And fluorescent in situ hybridization, which is commonly done on bone marrow aspiration, your paraffin histopathology blocks. This gives you a subtle submicroscopic structural which could be missed out on karyotyping is given in an enhanced manner on fluorescent in situ hybridization. Then again, a test of microarray based genomic hybridization, which give copy number changes. This is also is done in a lot of pediatric neurology cases, pediatric endocrinology cases, and your whole NGS basically, which is next generation sequencing, which is done when to give any kind of genetical chromosomal aberrations, which can be given. All and now because of these tests, the TAT time initially it was for months, but now it has come down. Now a whole exome sequence report you can get in a month frame or at most 6 weeks. um, a little bit on drug testing, which is because it is also done in a pediatric setup. The commonly ones are done are your phenytoin, valproic levels, and phenobarbital, which are anticonvulsant. Your antifungal level like VORI, which is very commonly done in our pediatric setup because of the transplant and patients who are immunodeficient. And because of the transplant setup, we often do cyclosporin and TAG and methotrexate level, which are generally done in cases of leukemia, your osteosarcomas. So why this therapeutic drug monitoring is done? with most medications, you need a certain level of drug in your body to get the proper effect. Some medicines are actually harmful also, and monitoring the amount of level found in your blood will help the clinician uh, to make sure the drugs are in the proper range. So a bit of take-home messages from my end and from the lab's end. Tests should be ordered after a very thorough clinical evaluation, detailed history and systemic examination. Cognizance should be there before ordering a specialized test. You cannot order a test where you are not aware of it. Proper interpretation of a specialized test by the clinician ordering. If you get the report, at least you should have a fine idea of what it is signifying. Most of the tests bore a huge cost to the patient. So explain the patient the importance of the test which is ordered. Post-test counseling is advisable if a particular test gives a life-altering diagnosis in case of a malignancy or genetic disorder. And when in doubt regarding a particular test, be it pre-test, be it analysis of the report or post-test or TAD, always please speak with the laboratory performing it. Thank you all. I'll be heading, this session will be now headed by Dr. Shaheen, our senior consultant in the microbiology department, who has experience of more than 20 plus.
Shefali, share करना. Shefali, help me share.
Yes. एक सेकेंड.
Stop sharing.
जाता है ना.
बाकी सब भी खोल दो. समझा.
ओके.
इधर क्लिक करो फिर. Include और तीसरा lab diagnosis. Come to Zoom. चलिए खुल गया. Very good afternoon to all of you. I'm Dr. Shaheen and I'll be speaking on 3 topics. करने में पहले मैं ठीक है lab diagnosis of tuberculosis. Very good afternoon to all of you. This is Dr. Shaheen and I'll be speaking on diagnostics in tuberculosis. So to begin with, the topics that will be covered in this lecture are specific tests like smear culture, molecular test, and non-specific tests in the form of fluid routine, ADA, ESR, tuberculin skin test, NIGRA. I'll be touching on all these topics. So to start with, is there a need to discuss tuberculosis? So tuberculosis is a disease of antiquity and found in the spines of Egyptian mummies. Is it still relevant in 2020? Yes. So India is the highest TB burden country in the world, and 1/3 of the population is infected. 1/3 of our population is infected, and 1/4 of the world's population is infected. Every 3 minutes, 2 people are dying of TB infections. What are the risk factors? Overcrowding, poverty, malnutrition, diabetes, smoking, alcoholism, HIV. Things are not going away anywhere, and therefore this disease is here to stay. So coming to the first modality of diagnostics is AFB smear. So the traditional method of 3 consecutive early morning sputum samples holds true even now, versus spot morning spot, which is also what RNTCP advocates. So 3 consecutive early morning sputum samples will also do, and spot morning spot sample will also do. What is spot morning spot? When the person comes to you
To give you an early morning sample, you ask for a spot sample and then ask for another one the next day. Why do you do all these things? Because the bacilli are intermittently shedded. There's no continuous shedding of bacteria. And therefore, to catch hold of these bacteria, you need to do these tests. What is the advantage of AFP smear? It's a simple test to perform. You get the reports the same day. And there is an RNTCP grading. And therefore, when the patient is treated, it also has prognostic value. So 3 plus can come down to 1 plus or scanty, indicating treatment, indicating that there is response to therapy. What is the disadvantage of AFP smear? It has got very poor sensitivity. It needs at least 1 lakh bacilli per ml for it to get detected. And therefore, smear is positive in pulmonary tuberculosis in only 50 to 70% of cases. But importantly, in extrapulmonary cases, the smear positivity is only 2 to 10%. Okay. I think people can't hear me well, so I'll speak a little louder. So far I've spoken about AFP smear, and I've spoken about the fact that it can be, it's a very simple test to perform. You get the reports the same day, and there's an RNTCP grading of 2 plus, 3 plus, 1 plus, and scanty, and it has got prognostic value. But the disadvantage of AFP smear is that it's got poor sensitivity, and therefore it can be detected in 50 to 70% of pulmonary cases and 2 to 10% of extrapulmonary. Now, coming back to the tubercle bacilli, why is it so different as compared to other bacteria like E. coli or CLEV, which grow in 24 hours and give the reports in 48 hours? Tubercle bacilli have got special requirements. They're very slow growing, they're infective, and they acquire resistance. So my question is there a need to do TB cultures? So you have an AFP smear, is there a need to do TB cultures? As stated earlier, your pulmonary cases only 50% get picked up by smears, remaining 50% are smear negative. In case of extrapulmonary, only 2 to 10% of cases are smear positive, and remaining 90 to 98% of your cases are smear negative. Because it's a paucibacillary condition and therefore it doesn't get picked up. And therefore, there is a need to do TB cultures. When you use the word culture, what do you mean? You mean that you're trying to grow the organism. So TB culture is where you're trying to grow the organism. Okay, there was the earlier modality of growing it on solid medium known as LG medium. And now we have, since the past 15 years, a modality of growing, which is the liquid medium. There are two methods of TB culture automated. One is MGIT, very popular. A lot of clinicians just write MGIT culture instead of writing TB culture. It's almost become like a generic name. And Bacterial is another machine which also does TB cultures. So what does it do? What is the advantage of doing it by liquid medium? Why don't we continue doing TB cultures by LG medium? Because the sensitivity is better and it grows earlier. So the liquid medium, the organisms can grow as fast as 10 to 14 days. That's the reason for doing. Now, what do these machines do? The MGIT culture detects the oxygen consumption in the tube. So when the bacteria multiply, the oxygen is consumed and that is picked up by the machine. Whereas in Bacterialert, it detects the carbon dioxide production. So when the bacteria are multiplying, they release carbon dioxide. And that is detected by Bacterialert. So Midget and Bacterialert are two equipments that are very widely used, but Midget, or MGIT as it is called, is the more widely used modality of TB cultures. This is how the equipment looks. Now, we go back to the tubercle bacilli, it's got special requirements, it's slow growing. So to fulfill all these requirements, the MGIT has got a supplement which allows the organisms to grow really well. Okay. Also, the commonest sample that you give is sputum sample and it passes through the oral cavity. So to kill all the other bacteria, it also has got some mixtures which suppress all the other bacteria. This is how the midget tube looks. There's a fluorescent dye at the base of the tube. Okay, so when the organisms grow, okay, the oxygen is consumed and the fluorescent dye gets unquenched and the dye starts emitting fluorescence. Okay, so the dye starts emitting fluorescence and that's how the machine picks up that the organism has grown. What does this machine do? This machine just monitors the fluorescence and incubates all the cultures at 37 degrees. What is the advantage of midget? This is a study that shows that in smear positive, it can grow as fast as 9 days. And in smear negatives, it can grow as early as 16 days, as compared to an LG medium, which takes weeks. So after we've grown the organism, we would like to do susceptibility. Do we want to do susceptibility testing to first and second line drugs? Is there a need? Yes, there is a need. We've got MDR TB, which is TB, which is resistant to INH and rifampicin. We've got XDR-TB, which is called as extensively drug-resistant TB, which is basically MDR-TB, which is also resistant to any fluoroquinolone and one of the injectable drugs. And we know that MDR-TB is common throughout the world and in India, and we have cases of XDR-TB as well. So there's a need to do this. What are the risk factors for MDR and XDR? If there is a previous history of TB, or if there's a history of partial or incomplete treatment, that's when MDR or XDR-TB is known to develop. So MIDGET or the MGIT machine by BD comes to our rescue even to do these antimicrobial susceptibilities. It does these antimicrobial susceptibilities in 2 weeks' time. What basically is done in this machine is that you take the tube, you put organisms in the tube, and you also add the antibiotic and allow the antibiotic and the drug and the bacteria, the Mycobacterium tuberculosis, to interact with each other. Okay, if the antimicrobial has worked, there will be loss of turbidity and there will be clearing of the tube. That will indicate susceptibility. But if there is turbidity, then the organism will multiply, okay, and show resistance. And I will show you what I mean. So basically, MCIT is US FDA approved for the first line drugs and WHO recommended for second line drugs. This is a list of drugs which can be tested on MGIT. You prepare the inoculum, you put it in the machine, let it incubate. Okay, and at the end of 7 to 10 days, you get a report which says whether it's sensitive or resistant. So to summarize so far, MGIT is a very good equipment used for growing the organisms and hence diagnosis and for susceptibility. But you're getting a solution in a month's time. Is it adequate enough? So what happened is, because all of this takes time, 2 weeks to grow the organism, 2 weeks to do the susceptibility, and you have a result in a month's time. We have other tests that came to our rescue in knowing whether the organism is drug resistant, whether it's MDR or XDR. So you've got molecular genetics that came to the rescue. There are 3 or 4 different tests that can be done in this. First is line probe assay. So line probe assay is a test that has been working in we've been using line probe assay since the past 10 to 12 years. Okay, there is a line 1 and a line 2. Basically, this is a molecular test that gives you results in the form of a line. Okay, so the final results are in the form of development of line. Therefore, it's called as a line probe assay. What it does is it detects the genes that are responsible for antibiotic resistance. It sees whether there is any mutation in those genes. Or it sees whether there are some regular genes which are missing. So there's a line 1 and a line 2. Line 1 detects the resistance to INH and rifampicin. And line 2 is for fluoroquinolones, aminoglycosides, and ethambutol. So it sees whether these lines are developing adequately for the wild types or is there any mutation that is developed. When do you do a line probe assay? See, basically a line probe assay is a very tedious test and you require the technician to be busy for 8 hours in this test. It can be done on AFB positive samples. Any sample which is AFB positive, you can run a line probe assay, and you can also run a line probe assay on MGIT positive TB cultures. The results are available in 8 hours, but the labs generally give it to you in 2 to 3 days. When do you do a line probe assay? When you suspect MDR-TB in the patient. So if you have a patient who's got history of inadequate therapy or comes from a house where there's another person who's got MDR-TB or has come to you after therapy failure or in confirmed MDR treatment for further therapy, you can use this. And it's got to have good sensitivity and specificity. So coming to another test which is very commonly used, everybody's aware of it, and that's the gene export TB test. So as I told you, line probe assay gives you results in the form of lines. What is gene export? So gene export TB test is a test which can be run both on pulmonary and extrapulmonary samples. It can be run on both smear positives and smear negatives. That's the advantage of gene export test. It's an automated PCR technology. It's a CBNAT. So it is the entire process of a PCR, which is normally done in 4 to 5 separate rooms, is done in one small cartridge, one closed cartridge. So it's called as cartridge-based nucleic acid amplification. So basically, there is one cartridge, you open the cartridge, put in a sample after a little pre-processing, close the cartridge, put it in the machine. The machine does everything for you. Okay, so there is no great, tedious, manual work involved. The hands-on time of the technician is only hardly 2 to 3 minutes. What it does is it tells you whether the sample has TB or not, and it tells you whether if there is TB, then whether there is rifampicin resistance. The results are available in 2 hours time. It's a very easy test to do. Not very technically demanding, and a lot of technicians can achieve competence in doing this. So it has an overall sensitivity of 88% and specificity. Importantly, remember, GeneXpert specificity is great. Okay, so basically, TB PCRs have been into existence since years. Okay, why did only GeneXpert get a WHO approval for diagnostics in tuberculosis very early? Is because it has got beautiful specificity. It's a PCR without the false positives of PCR. The earlier TB PCRs had a lot of false positivity because of contamination. The contamination gets eliminated in GeneXpert. And when I say this, I mean that if I have given a report of TB with GeneXpert, TB test, then it is TB and nothing else. The specificity is amazing. This is the take-home message for all of you. The specificity is amazing. The false positives are very low. And it has also got good sensitivity and specificity to detect rifampicin. So I hope I'm clear so far that we've spoken about smear, we've spoken about cultures, we've spoken about line probe assay, and now we're talking about GeneXpert. These are the various figures that tell you about how, apart from a sputum sample where there's amazing sensitivity and specificity, for the other extrapulmonary samples, how good is this test? So this test is pretty good for all other samples, hovering around 80 to 85%, except for pleural fluids where the sensitivity is poor. So doing a GeneXpert on pleural fluids is a little, you will be disappointed with the results. Coming to another test, so as GeneXpert has been into existence since 2012. Okay, and then there was refinement in the way the test was made, and they came up with GeneXpert Ultra. The reason why they came up with GeneXpert Ultra is because the earlier GeneXpert cartridge was capable of picking up only 121. The limit of detection was 121 bacilli per ml. So they came up with a better cartridge which picks up even lower quantities of the bacteria. So the GeneXpert Ultra that got introduced, I think, 5 years back, okay, has a limit of detection of 12.5 bacilli per ml. Amazing test, picks up TB in a lot of extrapulmonary cases. But unfortunately, some amount of specificity has been hit, and we find some false positives very rarely in pulmonary samples. Very rarely, I would say. So please continue asking for the test and depend on it. Just 2 years back, or I think 1 year back, GeneXpert came up with another cartridge which picks up. So now so the GeneXpert refined its picking up of MTB from 121 bacilli to 12.5. Okay, so now the picking up of MTB is good. Now the problem was with GeneXpert that you're only reporting rifampicin, and then we had to depend on a line probe assay for the remaining antibiotics. So GeneXpert came up with another cartridge a year and a half back, which gives you resistance to even more antibiotics, which is INH, fluoroquinolones, amikacin, and ethionamide. So it's an even better test, and it gives you results in less than 90 minutes. Imagine getting a result like this within 90 minutes, which tells you whether it's MDR or XDR quickly. Okay, within 90 minutes from a sample. That's amazing. Okay, and sensitivity specificities have been great. Okay, they have been WHO endorsed. One important impact that I saw in my hospital is that if you have GeneXpert Ultra result plus this MDR XDR, you know where to put these patients into isolation and prevent the transmission of the TB bacilli to other patients. And these are various articles and various statements from WHO recommending GeneXpert for the diagnosis of tuberculosis in adults, in children, and in smear positive, smear negative. So we finished GeneXpert. Okay, coming to another test that has now come into the picture is sequencing. So you must have heard of MDR and XDR sequencing. Okay, so nowadays, apart from these tests, there's also another test that has come up, and that is the pyrosequencing, XDR and MDR pyrosequencing test. So we need to understand that whole genome sequencing is a new buzzword, and sequencing is coming into microbiology in a big manner, in a big way. Okay, so it is also managed. The whole genome sequencing has managed to sequence the entire DNA of tuberculosis, the entire DNA of Mycobacterium tuberculosis. Okay, and Therefore, because it has sequenced the entire genome, it can rapidly detect drug resistance as well. So it can identify mutations, allowing the rapid detection of drug resistance. It has improved accuracy and gives you comprehensive information about drug resistance than the other traditional methods like MGI. The third thing is that it has enhanced our understanding of tuberculosis. So, in terms of epidemiology, genetic diversity, it has provided insights, which is crucial for understanding the evolution and transmission. And importantly, it gives you quick tailoring of treatment to individual patients, similar to what GeneXpert does. So this is a new buzzword, as I said, sequencing, but there are certain challenges that happen with any newly developed test, which is technically very complex. So the challenges with sequencing is that they're expensive. They require great specialized expertise. Any and every small and medium-sized lab cannot take a sequencer. The cost runs in crores of rupees. Importantly, despite getting the machine and getting the money to run the test, there's another important aspect is that it requires sophisticated bioinformatics tools and expertise, so artificial intelligence. And there's a lot of data interpretation that needs to be done, vast amount of data that gets generated. So it requires a lot of standardization as well. Therefore, it may not be readily available in all settings. Somebody like me sitting in the center of Mumbai, South Mumbai, can easily access this technology and get these tests done. But for areas which do not have access to sequencing, this may be a challenge. So to conclude diagnostics in tuberculosis, MDR and XDR TB is a reality. We're living in a city like Mumbai where we're getting exposed constantly to this bacilli. TB culture still continues to be the gold standard despite all your PCRs and sequencing and is a must and is not done away with. GeneXpert TB test is done in all cases, pulmonary and extrapulmonary, and now GeneXpert Ultra is giving you the limit of detection lower. It is helping you diagnose TB even better. And with the specialized GeneXpert, rifampicin and INH and the other antibiotics resistance, it is helping diagnose MDR and XDR better. Line probe assays can be done in all smear positive cases, and sequencing is a newer modality of diagnosis. Having said that, it will take time for all of us to understand the test, understand the utility of the test, and use it in our daily lives. Coming to miscellaneous tests, I'm just going to touch little about these other non-specific tests because these are very commonly used and everybody has some myths about the test, and I would like to clarify. Very quickly, coming to fluids. When you send pleural fluids or CSFs, what are the pointers towards tuberculosis? The sugars may be normal or slightly reduced. Cells will be raised with lymphocytic predominance. The presence of mesothelial cells in your fluids goes against the diagnosis. Coming to ADA. ADA is an enzyme which is involved in purine catabolism in most cells, particularly lymphocytes. And high levels of ADA, the full form of ADA is adenosine deaminase test. High levels are found in TB, malignancy, rheumatoid arthritis, CLLs, undifferentiated lymphomas, and empyremas. So it's not a very test which is specific only for tuberculosis. And this is the important take-home message that I want. Okay. How good is this test? If you have a cutoff of 40 IU per ml, then it is a pretty good test for both pleural, peritoneal, and pericardial. There's an article that talks about that if you take a cutoff of 100 IU per ml, then the sensitivity and specificity is almost 100% for pleural fluids for tuberculosis. Now, this is a very interesting fact that I found. I used to always wonder why patients come with pleural effusions and I don't land up growing anything in their pleural fluids, not growing any Mycobacterium tuberculosis. And even GeneXpert was very poor performing in detecting Mycobacterium tuberculosis. So the reason is that the pleural effusion in TB is a delayed hypersensitivity response to the antigens in the pleural space, and there is not much bacteria or bacilli present in the space. Coming to the next non-specific test, and that is ESR. It cannot be used to predict TB is the take-home message I want to give you. It's a non-specific indicator of inflammation and infection, and it can be found in many conditions all of us are aware of. So basically another article, very old article, which says that they studied the cause of high ESR in inpatient population, patients who are admitted in the hospital. And they found that the most common disease condition associated with high TB was infection. And the most common infection was tuberculosis. This was the only association that they found. There's another article that talks about 144 pediatric cases of tuberculosis, and they've concluded that because one-third of TB cases had normal ESRs, there'll be little value in using ESR as a diagnostic aid in childhood TB. This is an important message for pediatricians. Coming to tuberculin skin test, and a very common test loved by most clinicians and general practitioners. It measures delayed hypersensitivity to the tuberculin proteins. But one important message that I want to give you for tuberculin skin test is that it picks up both active disease and latent infection. As I have stated earlier, latent infection is found in one-third of us. One-third of India's population has latent infection. The bacilli is sitting dormant inside our body. And that is also picked up by tuberculin skin test. So a positive tuberculin skin test could very well just say that one-third of us are infected with TB and not disease. Okay, this is the important message that I want to give all. It's an intradermal skin test. You use 2 TU for children and 5 TU for adults. It's an intradermal test. You have to read induration and not redness after 48 to 72 hours, between 48 to 72 hours. Now, induration is hardness. Please do not read Mantoux test on telephonically or on cell phones, just looking at the images, because images will not tell you whether there is induration or very important message for all. Okay, you can't tell the patient, okay, you can't come for a reading, please send me a pic. That's just not. When will you do a tuberculin skin test? Considering that it's going to be positive in one-third of us, you may still. So, is there a utility to tuberculin skin test? Yes, there is. You will do tuberculin skin test in contact investigations. If you have a child, okay, who's in touch with another patient who's an open case of pulmonary tuberculosis living in close contact, you can do a tuberculin skin test and look for the positivity. Evaluation of recent immigrants. So in United States, people coming in from India or other countries with high TB burden countries, they evaluate using either a tuberculin skin test or another test that I will be speaking of. Then for screening of healthcare workers. So if you've got pulmonologists, you've got respiratory therapists, you've got technicians, microbiological working in the TB lab, for screening, you can do the tuberculin skin test. One disadvantage of this Mantoux test or tuberculin skin test is that typically, traditionally, it has been said that it may be affected by BCG vaccination, okay, and it may give you false positive results. So coming to a test which is used, abused, misused by a lot of people, okay, and is the IGRA test, typically known as TB Gold test. What does IGRA test do? What it does is, see, a patient who's either infected with TB or diseased with TB will have their T cells having some memory of the TB antigen. Okay, you take this blood of a patient. So this test is done from the blood. You take the blood of the patient, make it interact with certain antigens which are mimicking Mycobacterium tuberculosis antigens. Okay, because there is a simulation or a mimicker of Mycobacterium tuberculosis antigen, the T cells of the patient will start releasing gamma interferons. And it is these gamma interferons which are picked up by the TB Gold test or IGRA. It's a US FDA approved test. But importantly, the biggest disadvantage of an IGRA test or a TB Gold test, as I have told earlier, one-third of the Indian population will be IGRA test positive. Let's get this very clear. One-third of us are going to be TB Gold positive, and that is no indication to start therapy. What are the advantages of IGRA? It is not affected by BCG vaccination. It's very objective. So induration, redness, how it was measured, all that is out. And 2 patient visits are not. When will you use an IGRA? You'll use an IGRA for the same reasons you use a Mantoux test, for contact investigations, evaluation of recent immigrants, and screening of healthcare. One more concept that I want to very quickly give you. The utility of IGRA or TST is also, in case you have a TST positive in one-third of us, you pick up a population from the one-third of us who are likely to progress to active TB. And that population is going to be people who are malnourished, people who are on chemotherapy, people who are on immunosuppressors for any reason, including bone marrow transplant and organ transplant, inmates from prisons and old age nursing homes, children who are malnourished, patients who are on dialysis, and kidney failures. So in this small subpopulation of one-third of us who are IGRA positive or TST positive, chemoprophylaxis can be started. Why do you do this? You will do it to reduce the population or the denominator of TB and therefore will reduce the incidence and prevalence of TB. This is especially true in developed countries where the actual TB cases are less and they would love to reduce the denominators even further. Thank you. This is about TB diagnostics. खाली हेल्प कर दो कैसे करने चलो because we'll have workouts after this. I'll talk about blood cultures first. Voilà. इसमें ऑफिस जाओ नहीं ऑफिस जाओ रुको हाँ इसमें जाके यूटिलिटी ऑफ ब्लड कल्चर्स पे जाओ ओके Okay, so there's no escape from me. I'm going to be here with you for the next, I guess, 20, 25, 30 minutes. And I hope you all are paying attention and have not fallen asleep. Okay, coming to the next topic that I thought would be of use to you and of interest to you is blood cultures and its utility in clinical practice. So this is an important statement that I got in one of the articles as I was preparing for this lecture. No microbiological test is more essential to a clinician than a blood culture. If you find a pathogenic organism in a patient's blood culture, it has got great importance in terms of diagnosis, prognosis, and therapy. And blood cultures remain the mainstay of investigation for potential sepsis in infants and children. Despite the presence, again, I would say, despite the presence of innumerable number of PCRs and sepsis multiplex panels, blood cultures still hold true and they can still be, they are the gold standard in the diagnosis of sepsis. Okay, so identification of bloodstream infection is the most important critical task that any microbiologist does in the microbiology laboratory. Apart from just growing the organism, even a negative blood culture is just as important because it rules out cases of bacteremia and prompts continued investigation for other infectious or non-infectious causes, or at least it decides whether the empirical antimicrobial therapy that you've started, the antibiotic that you've started in the patient needs to be de-escalated or stopped. So negative blood culture is as important as a positive. What are the kind of organisms that are likely to grow depending on the age group? So a 2012 article says that infants less than 3 months, you're finding E. coli, group B streptococci, and Staph aureus as the common. Even in healthier children who are a little elder, after the first few months of life, the organisms that are commonly grown are Staph aureus, Strep pneumoniae, and Neisseria meningitis. But importantly, in immunocompromised patients, you may grow any and every organism under the sun, including Pseudomonas aeruginosa and Candida. So coming to the most commonest question that I always get, when will you send blood cultures? And this is a question that comes to your mind as well. When will you send blood cultures? So this was an interesting article and I've picked up from there. This says that collection is always recommended in the following conditions, always. When you're suspecting sepsis or septic shock or toxic shock, when you're suspecting meningococcemia, in investigation of prolonged fevers, you have a patient with prolonged fevers, not diagnosed, please send a blood culture. Blood culture has to be sent in case of fever of unorigin. Infants less than 3 months, any fever without source. Patients who are admitted for parenteral antibiotic therapy because of suspected bacterial infection, definitely send a blood culture, and in immunocompromised patients. So this is your important slide that you need to observe. When will you also send blood cultures is when you're suspecting bacterial meningitis, endocarditis, arthritis or osteomyelitis, pneumonias, severe and complicated pneumonias, not the regular ones. Then deep skin and soft tissue infections, okay, and infections in immunocompromised patients with intravascular catheter. So these are the, so why is blood culture being sent in all these very localized infections is because in every of these localized infections, when they get severe, there is outpouring of bacteria from that localized space or from that localized organ into the blood. So there is an element of bacteremia in all these conditions and therefore blood culture is recommended. Coming to the next slide. So the next slide says, when will you consider collection? Will be considered. This is not recommended. If you have a pneumonia which requires hospitalization, or you have a urinary tract infection which requires hospitalization, or a very complicated, suspected complicated appendicitis or peritonitis, or some complicated infection in your ENT region, okay, you may consider sending. And when will you not send? Okay, when will you not send blood cultures? In uncomplicated superficial skin and soft tissue infections, pneumonias that do not meet the criteria for admission, and pyelonephritis in healthy children without hospitalization. Okay, I've made things very clear. Now coming ahead. Why in community-acquired pneumonias are we... Okay, next slide is talking about pediatric pneumonias. Is it worth sending a blood culture in pediatric pneumonias? So this article states that you send blood cultures in patients with pleural effusions and those admitted to the ICU. They are the ones who are likely to have bacteremia and therefore positive. Okay, now coming to bacteremia. So what is this concept of bacteremia? All of us know that bacteremia means organisms floating in blood. There are two forms. One is primary and second is secondary. Primary is where you have the direct inoculation in the bloodstream, either because your peripheral lines are infected, your central lines are infected, or your IV lines are infected, or you are a drug user. That's when you have primary bacteremia. Secondary bacteremia, as I said, where there is an infection which is localized to one organ, and then it starts outpouring through lymphatics into the bloodstream. There are three types of bacteremia, and this is very interesting, and I hope you all are awake and listening to this. There's transient, intermittent, and continuous bacteremia. Transient bacteremia is what you and me face every day when we are brushing our teeth. Okay, it clears in a few minutes to a few hours. It may need prophylactic antibiotic therapy in a few conditions, which I will describe. So transient bacteremia is seen when you're trying to do an incision and drainage of an abscess, when you're doing any kind of catheterization. Dental procedure, flossing, brushing your teeth, endoscopy, instrumentation of any colonized mucosa, debridement of burns, or surgery of many of the contaminated sites or infected tissues. It clears in a few minutes, but it may need prophylactic therapy, and therefore you know that in case of dental procedures, you're given prophylactic antibiotic therapy, which covers streptococci, okay, which is found in the mouth. Streptococcus viridans causes infective endocarditis if in a few patients where you've not given prophylactic therapy, there is dissemination of the bacteria. Streptococcus viridans is the commonest of cancer. Now comes to that is about transient bacteremia. It comes and it goes on its own, provided your immune system is fine. Coming to intermittent bacteremia. So there are certain conditions in which there is a flush of these bacteria into the bloodstream, and then there is a period where there is no bacteria in the bloodstream. So it's intermittent. There is periodic seeding. When does this happen? If you have an internal organ abscess, you have fever and neutropenia, meningitis, healthcare associated pneumonia, osteomyelitis, pyogenic arthritis, and fever of unknown origin. When is there continuous bacteremia? And importantly, one important condition that I would like to highlight is first week of typhoid fever, there is continuous bacteria. So the bacteria are floating in the blood of a patient with typhoid, calling out and asking you to diagnose it doing a blood using a blood culture. They say we're floating here, please pick us up. Okay, it's that easy. Okay, so always do blood cultures in suspected typhoid. In other conditions like thrombophlebitis or your catheter-related bloodstream infections, there's going to be continuous bacteremia, and also in brucellosis. Therefore, blood cultures are of prime importance in brucellosis. Then there is another challenge with blood cultures. Okay, they can either be true pathogens or contaminants. If you grow organisms like these, Staph aureus, Strepto, Enterobacteriaceae, you know that the organism is causing the sepsis or bacteria. But there are certain organisms which are just skin bacilli, okay, like Strep viridans, Enterococcus, Coagulase negative Staph, Bacillus. These are contaminants which sometimes grow if you've not done the collection properly. So you need to optimize the blood culture collection procedure, which I will describe. So I always tell people that if you're sending blood cultures, do it in the right manner, with the right volume, in the right methodology, with the right collection, in the right bottle, with the right amount of blood added. Otherwise, don't. Okay, so if you're not cleaning the skin well, you're doing it half-heartedly, then the skin bacilli get into the bottle. The bottle doesn't know that this is a skin bacilli. It continues growing and you'll end up growing a contamination. So when you're doing a blood culture collection, it needs to be done using sterile gloves, using sterile cotton with chlorhexidine and alcohol combination. The cleaning has to be concentric and you need to disinfect the bottle top with alcohol. What do you use as a skin disinfectant? Earlier, tincture iodine and povidone iodine was used, but now chlorhexidine is used because it has got the lowest contamination rates. It has also got the lowest amount of time required to act. Okay, only 15 to 20 seconds. Okay, so it acts quickly. Okay, it gives a lower contamination. Plus, the irritation because of iodine, the discoloration of the skin, and the linen is circumvented when you use chlorhexidine, is avoided when you use chlorhexidine. So chlorhexidine is the material to be used. Make sure that you keep all your material ready before doing blood culture collections. Inspect the bottle and see that the bottle is fine and it's not expired. Clean the top of the bottle using an alcohol swab because there are references that tell you that coagulase negative stas is found on the top of the bottles. Then you just apply a tourniquet, clean your hands, wear sterile gloves. Why sterile gloves? Because articles are telling you that it reduces blood culture contamination by 50% because it's sterile procedure. Okay, clean with chlorhexidine with alcohol concentrically 2 to 3 times. I always tell my resident doctors first clean with spirit, followed by chlorhexidine and alcohol 2 to 3 times concentric. Do not blow and wipe off. So I have had technicians who've done the entire cleaning and then blowed into that area, and I've landed up growing Klebsiella pneumoniae in blood cultures. Okay. So once disinfected, do not touch the skin again. Okay. If you have to repalpate the vein, then kindly re-clean the entire procedure. Has to be repeated. Insert the needle, collect the blood. Don't change the needle because since the advent of HIV/AIDS, the changing of needle has been stopped. So old timers still continue changing the needle, but now it is out. Label the bottles. After you've added blood into the blood culture bottle, just move it 4 to 5 times inverted gently to ensure proper mixing. Label it, and importantly, don't label it on the barcodes because that's required for us while loading the bottle in the machine. There are 3 types of bottles available: pediatric, adult, and anaerobic. I'll just try to stress on this concept of paired blood culture. So paired blood cultures is where you don't send single blood cultures, you send 2 blood cultures. The 2 blood cultures can either be aerobic and anaerobic or 2 aerobics. Okay, and I'll tell you the conditions in which you will send 1 aerobic, 1 anaerobic, or 2 aerobic. Why do you send all these paired blood cultures? Because the more blood is tested, the positivity rate increases. These are the conditions in which you'll use anaerobic blood cultures in addition to aerobic in newborn and children. If there is a PROM, prolonged rupture of membranes, if there's an intra-abdominal pelvic infection, your host is immunocompromised, you find that there is poor dentition and oral mucositis, or there is fever of unknown origin and you've already done aerobic cultures and they're negative, or you have infections where anaerobic infections are likely, like necrotizing soft tissue infection. What is the volumes of blood cultures? There's an IDSA 2018 guideline that tells you how much ml of blood based on the weight of the patient. So this amount of blood has to get into blood culture bottles. In case you're collecting blood which is more than 5 ml, it needs to get into 2 pediatric bottles or 1 single adult. Okay. So these are articles that are telling you that there is a common concept. For neonates, we still continue taking only 1 single blood culture bottles, although there are centers that do 2 blood cultures. In neonates, the decreased sampling is because there's so less blood volume and there's a potential for increased transfusion requirements if you take too much of blood and the technical difficulties. We continue getting 1 bottle or maximum 2 bottles in neonates, but 1 bottle most of the times with 0.5 to 1 ml of blood added. But in elder children, I would like to state that the blood volume has to be sufficient. You can't presume that in bigger children, 0.5 to 1 ml will suffice, okay? Because that will result in false negative blood cultures. There are multiple articles that are talking. Coming to pediatric blood culture bottles, they are specialized blood culture bottles which support the specific requirements of pediatric patients. What are the requirements of pediatric patients? First, you're not giving too much of blood. Okay, so the bottle is still capable of growing the organisms, okay, despite small volumes. But that doesn't mean you give less volumes. And it is also capable of detecting all those fastidious, difficult to grow organisms like strep pneumonia, H. influenza, and mycelium. Coming to our next question, when will you collect blood cultures? So blood cultures, there are conflicting references that tell you prior to the onset of chills, at the peak of fever, anytime during the day. So these conflicting references have still not been able to decide which is the right time. But there's one thing that all references tell you is that the optimal time to culture is as early as possible in the course of a febrile episode. But importantly, it needs to be done before starting antibiotics. And that's the take home message for all of you. Don't do blood cultures after giving the patient 7 days of antibiotics. Do them, but you will not get so much of yield of organisms. So the timing of blood culture I have discussed with you. Administration of antibiotics. So the culture of sending cultures has to be there. Thankfully, in my institute, there is a beautiful culture of sending cultures before starting antibiotics, before escalating an antibiotic. You have a patient in the ICU who's been on piperacillin tazobactam for 3 days, gets a new spike of fever, you're suspecting a newer infection, okay, you're suspecting a drug-resistant bacteria. Before escalating the antibiotic, a set of blood cultures are sent. That beautiful culture of sending cultures is there in my institute. Okay. Administering antibiotics prior to blood culture will not, it's not, if you're going to push in antibiotics IV, the organisms will not. But yes, if the patient has been on 2 or 3 days of oral antibiotics, the blood culture bottle still may be capable of growing the organisms because of certain particles in them, which are sabudana-like particles. They're known as resin particles or polymeric beads. Okay, they're small sabudana-like particles. They're present in the bottle. Okay, what it does is when you're adding blood to it, the blood has got the organism, the blood has also got the antibiotic. So it takes the antibiotics, catches hold of the antibiotics, gets it absorbed on its surfaces. It doesn't allow the antibiotic to work on the bacteria. The bacteria grow uninhibited. Also, the RBCs get lysed because of these sabudana-like particles. So the nutrients are released, which even provide more fodder and food for the bacteria to grow. And it also lyses the WBC. So in case there are any intracellular bacteria, they get released. Automated blood cultures is the method to do blood cultures. Manual methods are now. Simply because automated blood cultures have lesser contamination rates. Apart from sending blood, you can also send pleural fluids, pericardial fluids, CSF, joint fluids in these blood culture bottles, and peritoneal fluids. What it does, there are US FDA approved equipments which are now present in all good accredited microbiology laboratories throughout the city. Okay, they pick up the carbon dioxide which is released by the dividing organisms, okay, either by fluorescence change or color change. So the color of the original bottle at the base changes to yellow if it is positive. The machine picks it up. Okay. The machine takes a reading at the base of the bottle and forms a dot here in the graph. And as the color change increases, the graph rises and the bottle is flashed positive. Okay. Now there's another concept of time to detection. Okay, in not just in pediatric but in other patients as well. So traditionally, it has been always taught to us and it has been fed to us that if it is 48 hours after a blood culture has been given, okay, and it is negative, you can stop antibiotics, withhold antibiotics, or de-escalate antibiotics. But the newer concept is only 36 hours, especially in the era of automated blood cultures. 36 hours is the cutoff now for blood cultures. Okay. There's another concept of time to detection. How soon has your blood culture come positive? It helps you find whether the bacteremia in ICU patients is because of the central line or it is because of some inherent problem within the body which is causing bacteria. So there will be, you send blood cultures from the central line, you send blood cultures from the peripheral line, and you look at the time to detection. Okay, if there's a 2-hour difference and your central lines have come positive first, as compared to a peripheral line, and there is a 2-hour difference, more than 2-hour difference, this indicates that your central line is the reason for the bloodstream. Okay, so this is the important point that gets picked up when you send paired blood cultures from central and peripheral. To summarize, best practices for pediatric blood cultures including getting a sample of adequate blood volume. That's the message I want to give. before administering antibiotics in any patients who have clinical signs of sepsis and the entire list that I mentioned earlier. Anaerobic blood cultures have limited value in immunocompromised patients' abdominal, head, and neck infections. And time to detection helps you detecting catheter-related bloodstream infections. Thank you. I hope you are still listening to me. And I hope you'll have some questions at the end of everything, indicating that you'll have listened to me very carefully. Okay. So as I said, there is no escape from me. And the third lecture on automation and microbiology and MIC values. So everybody does ask me why MIC values, how MIC values have to be used. This is going to be a very simple lecture on how MIC values have to be used in your daily clinical practice. Please listen to it carefully. Okay. So before I start talking about MIC values and automation and identification and susceptibility, the reason why microbiology came into the limelight the past 5 to 10 years is because of antimicrobial resistance. Okay. So WHO in 2014 stated that we are now entering a post-antibiotic era. If there is no urgent or coordinated action taken by many stakeholders, the world is headed for post-antibiotic era, in which common infections and minor injuries, which have been treatable for decades, can once again start killing. And this was a statement that's really an eye-opener. Another point that I would like to make is that there is a threat. The threat of antimicrobial resistance is real. It's not just whether your patient responded to your antibiotic or not, but globally and at a bigger level. Okay, it is estimated that in 2050, antimicrobial resistance is going to kill more patients than cancer. I would like to repeat again that it is estimated and it is projected. The word is projected, that if things continue the way they do currently, then antimicrobial resistance in 2050, which is 25 years down the line, is going to be the leading cause of death in patients. So I don't think we need to talk more beyond this. Globally, we are finding 44% of colistin. Colistin is the ultimate drug that you use for gram-negative infections. 44% of colistin resistance is now in India. Prevalence of another resistance mechanism called as ESBL ranges from 62 to 100%. And carbapenem resistance is ranging between 30 to 75%. What is happening in our backyard? The local Mumbai data of an article that got published actually by me a few years back, which shows this is a 3-year data where I saw community-acquired urinary tract infection around 10,000 isolates. And I found ESBL production at a very high rate there. Okay, so only 42% was sensitive. So 100 minus 42 is 58% ESBL. Okay. This was another data where I had around 220 isolates of Salmonella. I found fluoroquinolone resistance almost 89%. These are all community acquired. This is community acquired staph and in skin and soft tissue infections around 2,500 isolates. This is my data of 3 years. MRSA is to a tune of 12%. This is community acquired data. This is really an eye-opener. What are the causes of antibiotic resistance? So now, although Indian FDA has said that antibiotics cannot be prescribed and cannot be given to a patient by the chemist without prescription, we still continue getting over-the-counter antibiotics. Also, doctors may tend to overprescribe antibiotics. Patients may not be taking the antibiotics as prescribed, so the dosage is not adequate. There is poor hygiene and sanitation, poor sanitation practices, poor infection control practices in the hospitals and clinics. And importantly, colistin is getting used in sub-therapeutic doses in injections to poultry to enhance the quality of the meat that we get. So the chicken legs, the bigger the size of the chicken leg, the more the content of colistin. This is an important message I want to give. So why is it important? You can say, okay, fine, let the resistance develop. We will end up getting antibiotics also at the same rate. What is alarming is that pharmaceutical companies are now not investing in antibiotics. And they're saying Why they're not investing in antibiotics? Because they say that they're spending millions of dollars in the research, but the drug gets resistant in 2 months. So there is no return on investment. So the pharmaceutical companies have lost interest in development of newer molecules. Okay, so as the drug resistance has increased, the number of newer drugs in the market have reduced. So this is really alarming. Okay, so are there any solutions? So in India, representatives from NABH, ICMR, MCI, WHO policymakers from state, policymakers from state and central government sat together, deliberated on this issue and developed a roadmap. First of all, they came up with a national health policy, 2017. So it's very much available on the net, okay, which tells you for which kind of infections which antibiotics are. Okay, and it also tells you the resistance in organisms in the ICUs in our country at a bigger level. Okay, so the solutions are use antibiotics when required for the right indication, use the right antibiotic, use the right dose, use the right route of administration, give it timely, and then de-escalate it and record it. And importantly, send cultures before starting antibiotics and de-escalate when possible. Okay, and this entire gamut of the actions is known as antimicrobial stewardship. So then you would wonder why doctors aren't sitting in the laboratories talking big about antimicrobial susceptibility. We're talking about this because the lab has a role to play. Okay, the lab, when they give these culture reports, need to use updated guidelines, need to use updated technology, and need to interpret using MIC values and frequent events. So what are the guidelines for susceptibility testing? So US and UK and Europe have got certain guidelines. Unfortunately, we do not have any such guidelines.
Tell people to please just mute their audio. Thank you.
So CLSI and UCAST are two guidelines which telling us how to report cultures and use the appropriate technology. So we use automated diagnostic systems for identification and susceptibility. So automation came into microbiology around 12 years back. Okay, as compared to the age-old disk diffusion method, we now have the automated. I request somebody is talking. Are there any questions? Are you asking any questions? Or is it disturbing me? So please mute yourself, please. I request. So earlier you used to have reports where you had antibiotics and S and R written next to it. I've seen some reports where there was plus and plus is written, but there is no science to it. Okay, an ideal automated blood cultures would have MIC values reported along with the sensitivity. So how is this automation getting? We understand zone diameters and the disk diffusion method have got the inherent problem of subjective and manual. The entire process is manual. So it is greatly dependent on how thick the medium was, the pH, how good the disk was. So to circumvent all of this, automation came into microbiology. I'll talk about very quickly on how automation works. Please mute yourself, sir. Please mute yourself, sir. You're disturbing. Okay. So the basis of this automation is a smart card, which gives you the identification and susceptibility. Minimum
खेतों से मिट्टी का कटाव होगा, गेहूं से लेकर चावल तक सभी का उत्पादन आगे जाकर मिलेगा.
Mr. Anirudh Joglekar, please mute yourself. I request you to please mute yourself. You're disturbing me. Thank you. Okay, so the card gives you the MIC values. Okay, how it does is little interesting. Each window has got 3 antibiotics in it. Okay, what you do is you take the organism that you've grown and make it interact with these antibiotics at different concentrations. Okay, if the antibiotic is powerful and it kills the bacteria, then there'll be clearing in these windows, which is picked up by the machine. But if the bacteria is powerful and it's resistant, then there'll be turbidity in these windows. Okay, and this turbidity is picked up by the machine. So the clearing and the turbidity is picked up by the machine, and there is a figure that is computed, which is called as the MIC values, minimum inhibitory concentration. So there's a lot of jargon that is available on the net and in books and in articles talking about MIC values. But I will tell you one simple way of using these MIC values to choose the right antibiotic. So coming to a case, suppose if you have a 2-year-old female who comes with recurrent urinary tract infection, has got flank pain indicating pyelonephritis and fever with chills. You've done a CBC which shows a total count of 22,000 and a urine routine which showed plenty of pus cells, RBCs, bacteria. Your nitrite test was positive. You grew E. coli with a colony count of 10 days. Suppose if I give you a report like this, which has got 3 antibiotics, which I thought will work well in urinary tract infections, cefixime, augmentin, and nitrofurantoin. I give you a report that all of the 3 are sensitive. Which antibiotic will you prescribe? Little difficult. You could use your clinical acumen and decide on nitrofurantoin or augmentin or in your previous experience. But does the report help you decide which antibiotic to use? Okay, so if you have MIC values, you get a report which has got MIC values. Okay, so cefixime has an MIC value of 4, augmentin has 0.5, and nitrofurantoin 60. So would you choose augmentin as the best drug to use because it's got lower MIC values? No. So MIC values cannot be compared across classes of drugs. So one more important thing that is missing in all culture reports is the breakpoint MICs. So earlier, so let's come to the various ways. Earlier, we used to get reports only of sensitive and resistant. Then you started getting MIC values, but you didn't know what to do with them. You knew that the drug is going to work, but you didn't know which one to pick up from. Okay. So what is missing in most of the culture reports is breakpoint MICs. Breakpoint MICs are the values that are provided by the governing body sitting in US and in Europe, which have interacted these drugs and bugs, thousands of them, 10,000s of them at different points in time, okay, and looked at which MIC value will it. So breakpoint MIC of 4 for cefixime indicates that any value less than 4 is going to be sensitive. 4 or less than 4 is going to be sensitive. So cefixime is sensitive. It has an MIC value of 4 and a breakpoint MIC of 4. Augmentin, your bug, E. coli of that patient, 2-year-old female, got an MIC value of 0.5. But the breakpoint MIC is 16. CLSI is telling you that even if you get a value of 16, augmentin is going to. If you get a value of 8, the augmentin is going to. If you get a value of 2, augmentin is going to work. If you get a value of 0.5, it's definitely. Coming to nitrofurantoin. So nitrofurantoin, you got an MIC value of 16. CLSI tells you that the breakpoint MIC is 64. Okay. So you need to compute in your mind a ratio between the breakpoint MIC and the MIC value. So a breakpoint MIC of 4 and 2 is going to be 2. 16 upon 0.5 is going to be 32. And 64 upon 16 is going to be 4. So the drug of choice is going to be augmentin, which has the highest ratio of the breakpoint MIC upon the MIC value. This is also called as the therapeutic. This is stating things very simply, but there are many more things to it. For example, the antibiotic that you see here needs to distribute at the site of infection. Okay, that's important. Okay, now you also need to look at whether the drug is oral or IV and then decide the antibiotic. But if you have 3 drugs which are sensitive and which you can give, and you need to decide between the 3, then this is how MIC values are. So to summarize, I end your torture by saying that antimicrobial stewardship is the need of the hour to prevent further development of antimicrobial resistance. Automated identification and susceptibility helps in computing MIC values. It helps identify the organism more accurately. And MIC values, along with breakpoint MICs, help select an appropriate antibiotic and help in antimicrobial stewardship. I thank you for your patient listening. I hope a lot of you all are awake. Okay, and I stop sharing the slides. We can take questions now, if there are any questions. So I don't see any questions here except some comments. So I'll wait for another minute and then I will log out. Any more questions, please put in the chat box and we can answer. Okay. What is the cost of gene export test since TB usually occurs in malnourished belonging to the low? So the cost of gene export test, I think, is 2,200 single test. Provided, 2,200. Accredited laboratories and laboratories who get cartridges at lowest cost from the Bill and Melinda Gates Foundation cannot charge more than 2,000 for the gene export test. I don't think there are any other questions. So I will log out. Thank you for your patience.
Hello?
Yes.
Yeah, any particular antibiotic if we want to know? See, like, you all have something like, you all have decided on augmentin, you have decided of nitrofurantoin. But if we want to say, like, do it for this antibiotic, is it possible?
Basically, these automated systems have got panels which are preformed. They are imported from United States. Okay, so they are preformed and they've got a fixed set of antibiotics. Whatever antibiotics are there in the panel can be given to you with the MIC values, but whatever is missing, we have to go back to the age-old diffusion method and give it to you. 1. 2, I would like to state that these panels that are formed for Vitek are such that they include most of the commonest antibiotics that are used in infections. There's a separate card for urinary isolates, and there's a separate card for all the other isolates. So most of the microbiologists working in the city of Mumbai are catering to the needs of the doctors based on where the infection is from. So they make sure that the antibiotics that work well at that site of infection are reported.
Thank you.
Okay, can be blood culture sample after giving empirical therapy? The concept is to send blood cultures before empirical therapy and not after starting empirical therapy. The culture of sending cultures has to be developed. If you've still given an antibiotic therapy and the patient is not responding and you're at C finding out what it is, you can send blood cultures, but with the prior knowledge that the organisms may not. One question is, what if patients insist on antibiotics for viral flu? The patients may insist, but we cannot continue abusing, misusing antibiotics any further, considering the kind of situation we are in. So you need to counsel the patient and also if the patient is affording, then diagnose the viral flu. They'd be happier there, but you can't start antibiotics. Okay, I think we are done. It's 4:36. I hope these talks have been of some use to you, and I'll log out. Thank you. Thanks for your patience. Thank you.